All right, let's dive right into HER2 testing for gastroesophageal adenocarcinoma, or GEA. If you're a medical trainee, getting this right is absolutely essential for your patients, and we're going to break down exactly what you need to know.
So, here's our game plan. First, we'll talk about why GEA is such a tough cancer to treat. Then, we'll get into the discovery of HER2 as a target. After that, it's all practical stuff. The testing algorithm, how to score it, and finally, we'll talk about the huge role you play in making sure the results are accurate from the get-go.
To really get why this matters, let's start with a number. 43,280. That was the estimated number of new gastroesophageal cancer cases in the US back in 2016 alone. So yeah, it's a major health problem, and it's often caught way too late.
And that brings us right to our first section, the massive clinical challenge this disease represents and exactly why we needed a new weapon in our arsenal.
You see, for patients with advanced GEA, the outlook has historically been pretty grim. The treatments were mostly palliative, meaning they could help with symptoms, but they weren't cures. The prognosis was just very poor. We desperately needed something better.
And that urgent need for something better, well, it led researchers to a specific target, a biomarker that would go on to completely change the standard of care.
And that target is ERB2, though you'll almost always hear it called HER2. Think of it like this. In a normal cell, HER2 helps with growth signals. But in some cancer cells, it's overexpressed. It's like the accelerator pedal is slammed to the floor, driving that cancer to grow and divide like crazy.
So, the big question was, if we can block that stuck accelerator, can we stop the cancer? The answer came from the landmark TOGA trial. This was a true game changer, providing the first solid proof that targeting HER2 actually worked in GEA.
And just look at these results. When they added trastuzumab, that's the HER2 targeting drug, to standard chemo, the median survival jumped from 11.1 months to 13.8 months. Now, an almost 3-month improvement might not sound like a lifetime, but in the world of advanced cancer, that is a huge, statistically significant win. It set a brand new standard of care.
Okay, so a major breakthrough like that means you need a solid, standardized way to figure out which patients will benefit, right? And that's where the joint guidelines from CAP, ASCP, and ASO come in. Let's walk through the exact algorithm you'll be using.
First things first, the guideline is not subtle about this. It is a strong recommendation. That means the tumor tissue from every single patient with advanced GEA who could potentially get this therapy needs to be tested for HER2. It's not a suggestion, it's step 1.
The testing path itself is actually really elegant and efficient. Think of it as a 2-step filter. Every specimen starts with IHC, which is basically a staining test to see how much HER2 protein is on the surface of the cancer cells. If the result is a clear positive or a clear negative, you're done. It's only for those murky, in-between cases, the ones we call equivocal, that you move on to the second step, ISH, to get a final answer.
So what kind of tissue do you need? Good news here, you've got options. Whether you're dealing with a small biopsy, a big resection specimen, tissue from the primary tumor, or even a metastases, it's all fair game. Even cell blocks from fine needle aspirations can work.
All right, let's get into scoring the results. Now pay close attention here, because this is where GEA has some really important differences from other cancers you might have learned about, especially breast cancer.
The guideline is crystal clear. You must use the scoring system that was specifically developed and validated for GEA. That's the Ruschoff/Hoffman method. You can't just take the breast cancer criteria and apply them here. It doesn't work, and you'll get the wrong answer.
So here's how that IHC scoring breaks down for a biopsy. A score of 3+ is positive. A 0 or 1+ is negative. And that 2+, well, that's your equivocal result, the one that needs the follow-up ISH test. The pathologists are looking for staining on the cell membrane in a little cluster of at least 5 tumor cells. Now this right here, this is probably one of the most critical take-home points for you. In breast cancer, to call something positive, you need to see this nice, clean, complete circle of staining all the way around the cell. But in GEA, it's different. It's often incomplete, just on the side or the bottom of the cell, and that can still be positive. The staining is also a lot more patchy and heterogeneous. It's a huge difference. So for those equivocal 2+ cases that get the ISH test, the answer comes down to simple math. The test literally counts the number of HER2 gene copies and compares it to a control gene, CEP17. If that ratio of HER2 to CEP17 is 2.0 or more, it means the gene is amplified, The result is positive, and the patient is a candidate for anti-therapy.
Okay, let's bring this home with the last section, which is all about you. As a trainee, you are on the front lines, and your role in making sure these tests are accurate is, well, it's everything. It all starts with you.
This is so important to understand. The accuracy of this test is basically decided long before a pathologist ever looks at a slide. Your actions in the endoscopy suite, in the OR, on the floor, directly influence whether the lab can even get a correct result. These are called pre-analytic factors, and they are critical.
So here's your checklist. First, cold ischemic time. That's the time from when the tissue comes out of the patient to when it hits the formalin. That clock is ticking, and you want to keep it under an hour ideally. Second, make sure it goes into the right fixative, 10% neutral buffered formalin for the right amount of time. And finally, communication is key. Documenting those handling times helps everyone down the line. Nailing these steps is part of your job.
So as we wrap this up, I want to leave you with this question to really think about. On your very next rotation, when you have a patient with GEA, what's the one practical step you can take to make sure this testing process is perfect? Maybe it's just double-checking the time the biopsy was taken. Because remembering and applying this knowledge, that's how we make sure every single patient gets the right diagnosis and a shot at the best therapy we have to offer.